It's my pleasure to be here, my first time with the CML advocates, and I'm really happy because I'm working a lot with the Patient Association in Italy and with Felice Bombacci in particular, that I think that you know. But this is my first, let's say, global experience with the CML advocacy. I have to talk today about the European Leukemia Net recommendation. Indeed, you see that this is a first slide just showing that to present what is really the European Leukemia Net for chronic myelogenous leukemia group. European Leukemia Net is not only devoted to CML, it's an organization originally founded in Europe some years ago, and whose, I would say, aim was just to establish a number of cooperation between several countries, Western and Eastern Europe, including also other countries, and to give in particular, I would say, recommendation about the treatment of the disease in order to make the treatment quite uniform, at least in our region, in our continent. And however, the group taking care of CML probably was, we can say that it really represented the founder group of the European Leukemia Net, and this has been very active. It has already published in 3 different occasions recommendation about the CML treatment. And the first one was in 2006, the second one in 2009, and the third one that I will talk about has been in 2013. How does this type of recommendation really, how is formed? And you will see that there is a panel of international CML experts, and you see that there are more than 30 persons part of this group, not only European, but including also people from other continents, America, Asia, and Australia too. And you see that the way in which the consensus is achieved indeed is through, I would say, an online answering to several questions which are raised and generally posed by the coordinator of this group, who is Professor Baccarani from the University of Bologna. And after this, I would say, this counseling, online counseling, there are several meetings generally taking place in occasion of important congresses like ASH, and so on, in order just to discuss the major point of controversies that maybe have been seen in the answer to these questions. So let's start with what is written in the European Leukemia Net recommendation. First of all, I wanted to state that these are recommendations and not guidelines, which is the difference between guidelines and recommendation. Is the degree of evidence on which they are based. If they are based on a very, very high degree of evidence, these are guidelines you have to do in this way. Otherwise, you are out of what is the most, I would say, correct way to treat a certain disease. Recommendation is a little bit lower degree of evidence, and say that we think that, and we have data, of course, supporting what we believe about the treatment of a disease, but not all the data are still available. The evidence is of a minor degree, and therefore we can only recommend, but we are not, of course, these are not compulsory recommendation, I would say. And so this is a very important point just to be remembered, because as you will see, there are also discordances between the European and the NCCN guidelines that we will talk a little bit today later on. So recommendation, however, although they are quite clear and written and published, are not necessarily reporting the uniform opinion of all the persons who have contributed to their formation. And this is quite clear because, of course, it's a sort of the most accessible consensus between a number of persons who can have, however, still some discordant opinions about certain points of the treatment of CML. And all the rest has been already mentioned. Let's say which is the main difference and difficulties that we faced in 2013 with respect to the recommendation for CML treatment. As you may see, in 2006, the situation was quite simple. We had a single first-line treatment, like imatinib. We had very little options for second-line treatment, apart from the increase of imatinib dosage, and so on. Whereas in 2013, we have a totally different situation. We have 3 different drugs officially approved and registered for the treatment of first-line therapy. And Professor Shah already mentioned that these, imatinib 400 milligram, and nilotinib and dasatinib. We have a second-line nilotinib, dasatinib, but also bosutinib and allogeneic stem cell transplantation in specific group of patients. And as a third line, we have a new drug which is really effective also against the 359 mutation, which is ponatinib. And again, we have to consider the possibility to move the patients to allogeneic stem cell transplant. So we have also other possibilities, so in part already mentioned before, like the combination of tyrosine kinase inhibitors together with interferon alpha. And what has been a major change, however, is that before we were looking mainly to overall survival, and therefore to complete cytogenetic responses, and if you want also to measure molecular response, is a target to be achieved because this was associated with the best possible overall survival and also very stable response of the disease. Now we are moving progressively, but I would say also quite rapidly, towards new goals for the CML therapy, which means really the definitive and cure of the disease, and not only a functional cure, as we have seen in the presentation of Dr. Shah. So, there are also some very important observations which have been done in the period between 2009 and 2012, just forming the basis for the European Leukemia Net recommendation. In particular, we now know that a very fast response to the therapy is also very indicative of a better outcome for the patients. It expressed the sensitivity of the leukemic clone or leukemic clones, if you prefer, to the therapy, and therefore it's also give us it correlates very well with the future outcome of the patients, and this is extremely important. What we have now is also a better look on the outcome of patients treated with more potent TK inhibitors like the second generation TKIs, nilotinib and dasatinib as first-line therapy. And we know that the responses are faster and deeper with respect to what we can obtain with imatinib. And we know that these faster and deeper responses translate into less evolution to more advanced phase of the disease, in particular to accelerated phase of blast crisis, that we know still represent a problem, fortunately enough for a minority, but however a minority still existing of patients. And so this is a very important point. Finally, what is becoming very, very important, in part already addressed before, is that if we want to try to discontinue the therapy, and we will talk particularly on Sunday morning about this topic, we need, of course, to achieve a very low level of residual disease, reduction that in terms of logarithmic reduction means to go down to 4 log reduction or to 4.5 log reduction, to have the quite high probability of discontinuing in a successful way the therapy. And therefore, these are all very important points to be considered. Now, how can we evaluate the response to patients? This is a major point. There are 2 aspects that we have to consider. The first one is the degree of reduction of the leukemic burden. And the second point, which is extremely important, is also the time in which we are able to achieve a certain degree of reduction. Why it's so important? Because we know that, and this is a very famous slide that you have probably seen many, many times, then we are starting a diagnosis with an amount of disease, and we are reaching simply an hematological response, which means to go to level of white blood cell count, of platelet counts, and so on with a formula, which is really similar to that of a normal person without leukemia, but we do not have really a cytogenetic remission, so we call this a hematological remission. We still have that most of the cells are pH positive, and therefore it means that the median value of the BCR-ABL present at diagnosis is 100%. This is our, I would say, basic value on which we calculate the subsequent reduction of the leukemic burden. And this is very important because we know that the hematological remission, although from the aesthetic point of view, it may be, of course, of comfort, and because also it's the first response that we have to achieve if we wanted to have better responses later on. However, it's not per se sufficient, because in CML you can achieve also this type of response simply using hydroxyurea, but unfortunately this is not preventing the progression of the disease. We needed to go further down, in particular to achieve the complete cytogenetic response, not only the hematological response, which means that to have less than 1 residual leukemic cells out of 100 cells present in the peripheral blood and in the bone marrow, and just to have the best possible overall survival. This is what is correlated in a statistical way in all the analysis so far done with an improved overall survival. This is not preventing, particularly during the first 2-3 years, all the events of progression, but certainly the events of progression in patients who have achieved the complete cytogenetic response are quite and very rare, and therefore patients, this does not alter the outcome in terms of overall survival. You see that this corresponds to 2 logs reduction to move from 100% to 1% BCR-ABL according to the international scale. Then we can go further down, as everybody knows. If we are going 1 further log with respect to the threshold corresponding to CCYR, and we have to measure this using no more cytogenetic analysis, but quantitative PCR analysis, we are achieving the famous major molecular response, which was called the safe haven, which means that the patients not only has achieved I would say, the complete cytogenetic response, but also in a lower level, which is rather stable. And the possibility for these patients to progress are extremely low, I would say, and therefore really anecdotal. And this is what, for several, I would say, years, has represented indeed the best goal that we could achieve in CML therapy. And this is corresponding, of course, to a percentage of BCR-ABL measured with the RQ-PCR to 0.1%. But what is a more recent acquisition, which is becoming very, very important, is just to go further down. And what previously was called complete molecular response of CMR. And complete, why complete? Complete is not complete, frankly speaking. It means that we can no more see the BCR-ABL transcript. We will perform the traditional PCR analysis. And therefore, apparently, the transcript is absent. This was the official and original definition. But now, because our methods to identify minimal residual disease has improved, they have improved, particularly also because we are more sensitive in detecting residual disease. Now we know that the disease is still there, but we prefer just to say is below a specific threshold. And this threshold has been moved to 4 logs reduction to 4.5 log reduction, and therefore we call this MR4, MR4.5. And this is, I would say, to give a more precise definition to this very, very low level of residual disease. You see this is the corresponding value of BCR-ABL that everyone should be familiar with, just saying which degree of reduction in the leukemic mass we have obtained with a given therapy. Why is so important MR4, MR4.5? It's very important because we know that in a percentage of patients, we can say approximately 50% of patients, with some consideration that we will do later on, it's possible to discontinue the therapy without having a recurrence of the disease. Recurrence of the disease doesn't mean that the disease comes back again. It means simply that the BCR-ABL is becoming again visible. So the patient is perfectly good as it was before, but whereas before with the PCR it was impossible to see the disease, the BCR-ABL transcript reappears. Sometimes it reappears and it goes up, and therefore we will have, if we do not retreat the patients, let's say, the loss of the cytogenetic response and maybe also the loss of the hematological response, although we generally do not allow this. But in other occasions, there is a sort of fluctuation of a minimal amount of residual disease that then progressively disappears. So this is an extremely important phenomenon that we are currently studying, but you can easily understand that this represents our final goal. We wanted to defeat the disease in a very, very stable and definitive manner without the need of continuing to assume the drug for the rest of our lives. So these are the relationship between the outcome and the leukemic burden reduction. But what is becoming very important is that the timing of the response, which is extremely now anticipated, we can say, with respect to what was only 4 years ago. You may see that in 2009, we were more relaxed. And we were waiting for complete hematological response after 3 months, for at least partial cytogenetic response, which means reduction of 1/3 in the leukemic burden from 100% to less than 35% after 6 months, to complete cytogenetic response after 12 months, and then to MMR after 18 months. Now we have anticipated all these goals and in a more, I would say, in a quick way. And therefore, we are looking not only for complete hematological response, but also for partial cytogenetic response or the corresponding value of BCR-ABL, which is approximately 10%, a famous cutoff of 10% already shown by Dr. Shah, to be reached within 3 months from the start of the therapy. We are looking for CCYR not after 1 year, but after 6 months. We are looking for MMR after 1 year, not after 18 months. Therefore, everything has been anticipated. And this was based on a number of observations, which are probably one of the major advances that has been done in the very recent year concerning the treatment of CML. Because all the data shown in several studies, I would say more than 10 studies, have clearly shown that if we put a cutoff of 10% of BCR-ABL after 3 months of therapy, as in the case of imatinib and the picture that I've underlined here, you may see that there is a statistical difference in terms of overall survival. So those patients who are below 10%, they tended to have an optimal overall survival on the long run, I would say after 5 years. If we are going just to be above 10%, the outcome is inferior in terms of overall survival. So it's approximately 80% after 5 years. And therefore, this means that this is extremely important to predict the future response of the CML patients. And we can do this prediction very early on, after 3 months of therapy only. But what is very important is that, the same is true also if we are using more potent TKI. You see, if we are using dasatinib, it's exactly the same picture. There is apparently no difference. They are very similar, almost a copy one of the other. And the same is with nilotinib, as you may see, with respect to imatinib. This is what is coming out from the most important comparative studies between imatinib and nilotinib and imatinib and dasatinib. So what is the difference? The difference is that if we are using one drug, imatinib, 400 milligram, let's say the traditional treatment, the patients who are having this type of curve represent 1/3 of the total, 33%, whereas if you are using nilotinib, only 10% of the patients are falling in this, let's say, inferior outcome category. Of course, there is a difference which is statistically significant. You can say that, however, even the curve in this type of patients who are above 10% are not so dramatic, and this is true. In comparison with other types of leukemias in which the overall survival is very poor, the survival that we are having in CML is wonderful, we can say. But the problem is that, of course, we are looking for the perfection, and therefore we need, of course, to transform and to put these curves very similar to that of a control population without leukemia. Another very important point, which can be seen also after 3 months of therapy, is represented by those who are not below 10%, but those who are below already after 3 months, below 1%, they have the highest possibilities of, again, achieving later on, in a 5 years' time, a percentage of complete molecular response, or MR 4.5, as I told you before, or approximately 70%. And again, the curves in the two panels are very, very similar in respective if we are using imatinib or nilotinib. But again, the difference is the percentage of patients who are achieving this goal with imatinib, which unfortunately is only 16% of the patients, with respect to what we can achieve if you are using nilotinib. That is more than 0.5% of the patients, 56%. And this is extremely important. So all these data put together tell us that it's very important to monitor the patients, particularly during the very early phase of the treatment, to see how rapid is the reduction of the BCR-ABL transcript. It's one of the most important predictive points. So, however, as not all the types of therapies that are presently registered are registered all over the world, and we have to provide something which is valid for different countries, different parts of the world, and so on. In the European Leukemia Net, there is no specific recommendation for a specific TKI, because this is a medical decision. I would say also a medical and patient's decision. It depends on what you want to achieve, because it's very important that to note that if you are using nilotinib or imatinib, or if you are using dasatinib or imatinib, for the moment there is no statistical difference in terms of overall survival. This is important to know. Maybe it's becoming very important for the possibility later on to discontinue the therapy. So it depends on our goal. But our first goal still needs to be overall survival. And of course, at this regards, all the TKIs are similar, or not, and therefore, if our goal is overall survival, not a specific TKI can be recommended for the moment. So, depends on what you want to achieve, but for the moment, you can use at the diagnosis one of the 3 registered drugs when these are all 3 registered for first-line therapy. Certainly, however, what is clearly established in all the guidelines is that you have to be very careful to the reduction of the BCR-ABL amount, or if you do not have access to a good molecular analysis, you can also rely on a correspondent cytogenetic analysis, which is also good. So making a comparison, which means partial cytogenetic response similar to the 10% cutoff, and complete cytogenetic response similar to the 1% cutoff. And certainly all those who are not achieving the 10% cutoff after 3 months or the 1% cutoff after 6 months are non-optimal responders. This is true because for this group of patients there is indeed a difference in overall survival. So this is what is saying the European Leukemia Net. We cannot really recommend one of the first-line treatment at the moment. It can be imatinib, nilotinib, or dasatinib. It is a medical decision, and the doctors, but in combination, of course, with the patients, as to decide about the treatment in the best way for the patients who is, of course, treating, because this is very important. Depends also on the goal that you want to achieve. On the other side, a higher dose of imatinib, which has been a matter of discussion, as well as the combination with imatinib with interferon, also another very important hot points. There are data, but the data in the literature are not uniform, are not really, sometimes they are partly discordant. Therefore, for the moment, we cannot recommend outside an investigational study the use of these approaches, combination between imatinib and interferon, or to start with higher dosages of imatinib, as suggested, for example, by the German group in the recent German 4 study publications. However, this is something which is still matter of investigation, and certainly it's worthy, however, of particular attention. Why is free, let's say, is not compulsory, the drug with which the treatment should start as first-line therapy? Because, of course, in terms of efficacy, for example, second-generation TKR apparently are more efficacious in terms of all the surrogate endpoints, higher molecular response rate, and so on. But we have to look also at the safety, the long-term effects that we have talked before really can be different from one drug to another. And in particular, in specific patients, it can be more useful to use one drug with respect to the other for the specific characteristics of the patients. Then also the side effects are extremely important. And we have to consider also the quality of life of the patients. Let's say, is also life needs in terms of age, several comorbidities, of course, the education, the compliance to the treatment. So it's really, it seems easy to treat patients with CML, but it's not easy at all. And this is a point that should be carefully considered. What is extremely important, however, that the treatment should be strictly monitored. It's very important to have informations about the cytogenetic response, as well as also the molecular response, even in the very early phase of the treatment of the disease. Indeed, before we were relying on the cytogenetic response until the achievement of complete cytogenetic response. As you have seen, this 10% cutoff is becoming really imperative during the early phase of the patients. Then molecular should be, even after the achievement of CCYR, should continue every 3 months to be really regular. It can become maybe a little bit relaxed after when the patient has achieved a stable MMR for a certain period of time. Maybe you can rely on a longer period of observation of 6 months, particularly in specific situation. And of course, you have to look carefully if there is an increase of the BCR-ABL amount, because this may sometimes just represent a warning for not adherence to the therapy on one side, or maybe for the the onset of a really resistant clone, in this case preluding to a real failure of the disease. Monitoring, therefore, an essential part of the treatment. But please do not be obsessed by you would say, not obsessed in terms of, I would say, compliance to monitor, but of course you cannot always rely on a single analysis, because sometimes labs are wrong, there are mistakes, and so rely on more than one observation, in particular before taking important decisions concerning the treatment. So these are the treatment policy, and you may see that you can start with imatinib, nilotinib, or dasatinib as first-line therapy. Of course, in failing, you have to move to another TKI treatment. In particular, you have to move from imatinib to second-generation TKI according to the patient's profile or to the mutations which are causing the failure. And it's very important, a new point, that we have now third-line therapy with ponatinib, which is a drug very powerful, with also some important side effects, in particular thrombotic events, but that in specific cases is extremely important. And also, in some specific cases, we have to rely and maybe to consider also allogeneic stem cell transplantation for patients in which we know that the risk of having a relapse of progression of the disease is quite high, and the response to all the TKI treatments so far available are not very good. So for those who are not optimal responders, when we have to try to change therapy, and this is the main topic of discordance now between the European Leukemia Net 2013 and the NCCN guidelines. NCCN is a National Cancer Center organization, which is, I would say, including a number of important institutions in the United States which provide also recommendation about the treatment. In European Leukemia Net, indeed, the optimal definition is very clear, but what has been decided to do is just to distinguish in between those who were not optimal responders, to further distinguish between an overt failure. In this case, of course, what we have to do is to switch the therapy, and a so-called warning category, which is not, unfortunately, so different from what previously was called a suboptimal response. What does it mean? It means that the values are intermediate between optimal and failure. At this point, we do not know the outcome of the patients if we are changing therapy. Therefore, if we are, for example, on imatinib, you can wait and monitor more closely, but we cannot recommend at the moment to change therapy in a, I would say, in a very overt manner, because mainly we do not know at this point, after 3 months of therapy with imatinib, to change therapy at this point with second-generation TKI could be a real benefit for the patients. We are lacking data. We are waiting for the results of some study, but for the moment cannot be recommended. But this, if not recommended, does not exclude that we can wait and monitor, but maybe we can also change the therapy. And indeed, this is what has been suggested by the NCCN guidelines version, even into very recent edition of 2014. Indeed, they recommend for those who are above 10% after 3 months of therapy to change therapy, which means if you are on imatinib, to first change it to second-generation TKI, maybe after to third generation, and so on. If you are from the beginning in second generation TKI, you have several other options. According to the mutation, you can go to the not used TKI, therefore from nilotinib to dasatinib or vice versa. Or you can move to third generation TKI like ponatinib. In specific cases, you have to consider for this approximately 10% percentage of patients. Also, you have also to consider allogeneic stem cell transplantation if there is a donor, in particular if the patient is young and so on. So there is still some very important points which at the moment are missing. But I think that what is really important is that every 2-3 years or 3-4 years, we are having a big change in the CML therapy, as you have seen with this edition of the European Leukemia Net 2013. And therefore, on behalf of all the panel of the experts, I want to thank you for your attention.
Yeah, Professor Saglio, I got 2 questions. Regarding the first and second generation TKIs, you say nowadays, according to the European recommendation, it's up to the medical doctors and the patient to decide how they want to do. But from a cost perspective, as we all know now, the second generation TKIs can achieve, is much more superior in achieving this rapid response. So, but most medical doctors are reluctant to change. So I was just asking whether, is it possible for patient to first go on the first 6 months or 3 to 6 months to go on the second generation TKI to achieve very good deep response. Then subsequently, if they do mutational analysis and find that it's no problem, then they can switch back to imatinib, for economic reasons.
You are anticipating, this is a very good question, thank you. You're anticipating one of the protocols that we would like to perform in the next. We do not have data at this point, but it's likely that if we start with a sort of induction therapy with a very potent TKI, then maybe, although every time that you are changing treatment, you may expect to have approximately 10% of 12% of the patients are not tolerating well the new treatment, so they want to continue with the same drug. But I think that this is a very important point. The reason for this is, of course, that is the cost. What can be against this type of approach can be the fact that if you are able to achieve the same level of minimal residual disease, if you wanted, and to try to discontinue after a shorter period of time. So there are many problems to be solved, but of course the idea is worthy of a further investigation.
Okay. Second question is regarding the 4.5 log reading. Currently, I presume it's because of the detection, the accuracy of detection. If the detection accuracy improved further, say to 5 log, what will happen then? Would it change the criteria again on the for the stop trial?
At the moment, there are several. We will talk this on Sunday morning in particular. We can presume that the lower we are going, better it is. At the moment, our limit of detection, approximately with the methods that we are using, is 4.5, maximum 5%. But there are now new methods, in particular what we call digital PCR, which is an absolute evaluation of the transcripts. Okay. And it's likely that we can follow, indeed, and we can achieve a better, I would say, success rate if you are going farther down. What we know is that if we are taking a group of patients which are PCR negative, we can say, no, so below 4.5, and we are looking with the digital PCR, with the more sensitive techniques, all of them, generally, they still have residual disease. If in these patients we discontinue the treatment, however, we can have a progressive decrease of the disease in most of them. So they are going farther down even without therapy. And this is an extremely interesting phenomenon whose biological basis still needs to be explored, and of course it's very important, however, to understand which are the biological reasons for this response of the leukemic clone, which is apparently has lost is what we call clonogenic activity, so the ability to re-expand.
My name is Edward. My question goes to Dr. Giuseppe. From your presentation, you said, according to European Leukemia Network recommendations, the minimum dose for patients taking imatinib is 300 milligrams. Isn't there a scenario where a patient can respond positively to 100 milligrams?
How much?
100.
100. 100 is very low. You need a certain concentration of imatinib to have in the plasma level to have a good of course value, which for children has been calculated to be 370 milligram per square meter, so generally lower than the 400 milligram. but 100 is very, very low. I think that 200 you can expect a sufficient dose of imatinib to have in most of the cases, but you know, imatinib, the therapeutic window is very, very similar to, so it's quite limited, and therefore to go very, very low, particularly at the beginning of the disease, and when you a diagnosis, it may be dangerous because you may select a resistant clone.
Now, because this is, as in, I personally have been taking 100 milligrams for now, I think, about 2 years. Does that imply that I'm not responding to...
No, you're meaning after, but you started with 400 milligram.
Yes, for about 6 months, then later on...
Then you achieved the CCYR?
We don't know.
I'm not certain because the only test we do in Uganda is...
So this is very important because there is a study now performed in Italy, maybe then Neil can comment on this, in which in patients for a quite long time on complete cytogenetic response and major molecular response, it was allowed to reduce the dose of imatinib by, this is a sort of intermittent therapy of 1 month yes, 1 month no. And in this case, indeed, some patients will continue to respond even with a lower dose of imatinib, but it was not a lowering the dose. It was just a period of suspension, then restarting the therapy. And I think that 100 milligram is probably not the optimal dose, really.